Diagnosing iron deficiency requires looking beyond simple blood counts, specifically at serum ferritin, which generally reflects total body iron stores. However, interpreting this value requires nuance because ferritin is an acute phase reactant, meaning it can be falsely elevated in patients with inflammatory states, such as chronic kidney disease, heart failure, or autoimmune conditions. In a patient without significant inflammation, a ferritin level of less than 45 nanograms per milliliter is highly specific for iron deficiency. By contrast, when a patient has a coexisting inflammatory condition, the diagnostic threshold must be raised to avoid missing cases of functional iron deficiency. In these inflammatory contexts, a diagnosis is confirmed with a ferritin of less than 100 nanograms per milliliter, or a ferritin between 100 and 300 nanograms per milliliter, if accompanied by a transferrin saturation of less than 20%. Once deficiency is identified, determining the underlying cause becomes a matter of urgency, particularly in men and postmenopausal women. In these demographics, the default clinical assumption must be gastrointestinal blood loss until proven otherwise, as up to 9% of these patients may harbor an underlying malignancy. This makes a thorough evaluation with bidirectional endoscopy, both an esophago-gastroduodenoscopy and a colonoscopy, a non-negotiable step that should not be delayed by simply starting empiric iron therapy. While a trial of iron is reasonable for premenopausal women with clear causes, like heavy menstrual bleeding, other adults require testing for common malabsorptive causes, including celiac disease and Helicobacter pylori infection, alongside their endoscopic workup. When it comes to oral repletion for these patients, the traditional approach of prescribing iron multiple times a day is often counterproductive. Iron absorption is tightly regulated by the hormone hepcidin, which blocks intestinal iron absorption in response to elevated iron levels. A single dose of oral iron can raise hepcidin levels for up to 48 hours, rendering subsequent doses largely ineffective. Consequently, studies demonstrate that dosing oral iron every other day is superior to daily dosing. This schedule allows hepcidin levels to fall between doses, resulting in greater net iron absorption and significantly fewer gastrointestinal side effects, such as nausea and constipation, thereby improving patient adherence. However, for certain high-risk populations, oral iron is simply not enough. In patients with symptomatic heart failure with reduced ejection fraction, iron deficiency acts as an independent predictor of poor outcomes, even in the absence of anemia. Landmark trials like AFFIRM-AHF and Ironman have established that intravenous iron is the standard of care in this setting, as it improves exercise capacity, enhances quality of life, and reduces hospitalizations. Oral iron is often ineffective in heart failure patients due to gut edema and inflammation-driven hepcidin spikes. Therefore, intravenous iron should be utilized for any symptomatic heart failure patient with an ejection fraction less than or equal to 45% who meets the specific ferritin and saturation criteria for deficiency. While intravenous iron offers significant benefits, clinicians must remain vigilant regarding formulation-specific side effects. Ferric carboxymaltose has a notable association with inducing hypophosphatemia, a condition mediated by the stimulation of fibroblast growth factor 23. This hormone promotes renal phosphate wasting, potentially leading to severe fatigue, muscle weakness, or bone pain. It is crucial to monitor phosphate levels in patients receiving this specific formulation, particularly those with kidney disease or vitamin D deficiency, or to consider alternative formulations like ferric duracemaltose, which carry a much lower risk of this complication.